Perfect. Okay, hello everyone, and welcome to Anpa DMV Educational Series. This month is Vision Awareness Month, and the title of our webinar is Your Eyes Are the Windows to Your Health. I am your moderator for this event. My name is Dr. Nkem Okeke. I am a member of the Anpa DMV Education and Academic Committee, and my day job is serving as CEO and Physician Executive of Medical Links. Medical Links is a healthcare advisory and population health management firm that supports healthcare payers and providers to improve healthcare outcomes and return on their investment. Our special guest and presenter for today is Dr. Renee Bovell. Dr. Renee Bovell is a renowned ophthalmologist with a combined 20 plus years experience in clinical practice and cybersecurity. Dr. Bovell is the founder and CEO of Envision Eye and Laser Center, currently serving more than 15,000 lives in Maryland. She's also the founder of Cybersecurity MD, an early stage cybersecurity advisory service. Dr. Bovell has national leadership roles in the American Academy of Ophthalmology and has had multiple academic appointments. She is a board certified ophthalmologist and graduated from UCLA School of Medicine and completed an ophthalmology residency at Yale University and a corneal refractive fellowship at LSU Eye Center. She also holds a master's in cybersecurity strategy and information management from George Washington University. She's passionate about innovation and security of the healthcare technology infrastructure that are vital to healthcare delivery and, of course, the health of your eye. Other accomplishments include serving on the advisory board to several pharmaceutical companies, serves on the board of directors of Ophthalmic World Leaders. She's the president of the Maryland Society of Eye Physicians and Surgeons. She's a lead senior physician advisor to HealthLinks Care Transformation Organization, which is my organization, and I'm still lucky to call her friend. Welcome, Dr. Bovell, and I'll hand this over to you to share your insights on eye health. Dr. Bovell.
Thank you, Dr. Okeke, for that wonderful introduction. The way you say it, it sounds fabulous. Thank you. Okay, I hope everyone can see my screen. And today, we're going to talk about the eyes being the windows to your health. I chose this title because I became fascinated with the eyes when I realized you can look at the eyes and look inside the eyes and see how the body was working in its pristine state. We're going to talk about ocular manifestations of systemic disease. That is why the eyes are the windows to your health. A lot of what goes on in the body is manifested in the eye. And we'll talk about everything from the front of the eye, the cornea, to the back of the eye, dealing with the retina, and it's going to be exciting. I'd like everyone to know, and this is for both physicians and patients, most people should maintain good vision as they continue to age. I don't want people to come away with thinking that, oh, as I get older, I expect my vision to go. No, you should be able to maintain your good vision. Now, there are some normal things that happen as we mature. The need for reading glasses is normal. Changing eyeglasses is normal. Sometimes the eyes may become irritated and the external eyelid skin changes may be seen as well. First, let's go over the anatomy of the eye. The front part of the eye is called the cornea. That's the part of the eye when people who wear contact lenses, that's what they touch. They're putting the contact lens on their cornea. Behind the cornea, this is a side view of the eye, this is a front view, this is a front view, is a space. It's filled with aqueous, which is sort of the consistency of water. It's a liquid. Then you have the iris. The iris is what makes the eye brown or blue or green or hazel. The iris has an opening in it called the pupil. Here you can see the pupil. It looks like a black circle. Okay, that's the pupil. So the pupil is just an opening in the iris. You can't touch the pupil. Behind the pupil is the lens. The lens is what turns into a cataract as we age. Behind the lens is an area called the vitreous. This is a jelly-like substance, and it helps to maintain the shape of the eye. And then this orange part is the retina, and interspersed throughout the retina, sort of like lasagna, are the blood vessels and the nerve fibers, and they coalesce to form the optic nerve. Now, the optic nerve is what you see when you look at a skeleton and you see that cable. This is the eyeball, and you see the cable connecting the eyeball to the brain. That's the optic nerve. You also have the sclera, which is the white part of the eye. Everybody has this caruncle, which is kind of pinkish. And over top of the sclera is the conjunctiva. So let's talk about some of the issues. Sometimes you can see this, blepharitis. Blepharitis occurs in the upper and the lower lids when the glands that make the oil that keep the eyes nice and moist get clogged. You can see this kind of looks like toothpaste when really it should look like oil, sort of like olive oil. This is pigment. This is nothing to worry about. It's normal to see pigment on the conjunctiva. This is an infrared study showing the glands that make this oil. All of these little white areas are nice, healthy glands. But you can see in this picture, they're shrunken and non-existent. We want to make sure that does not happen to your eyes. Here's another picture of blepharitis. And some of the symptoms of blepharitis can be irritation because you don't have this nice oil coming on your eyes. Sometimes it can be kind of crusting. It makes you want to wipe your eyes. You can see there's sort of crusty material around the eyelashes. Sometimes it can make the eyes kind of swollen and red. And the eyes can become red or light sensitive or feel like they're burning even sometimes. It can also lead to a chalazion, that's what we call it, or what you may know as a sty, or some people call it a star, but it's a bump because those glands get clogged and the material can't come out through here, so it sort of backs up. If that's not treated properly, sometimes we can get a cellulitis, which is inflammation and infection around the skin of the eyelids. Next, I'd like to talk about the tear film. As we've been on the computer a lot, doing these Zoom calls, wearing our mask, having air blown up against our eyes instead of coming out this way, you may find that your tears aren't as healthy as they should. I'd like you to know the tears are not just what's in the bottle of artificial tears. It's a complex mixture of proteins and electrolytes and antibacterial factors, anti-inflammatories, and electrolytes. So what are some of the predisposing factors for dry eye? Well, as we age, it can be increasing in postmenopausal women because of hormonal changes. Certain medications, sometimes blood pressure medications, the diuretics. Now, I don't want people to think that because certain medications can cause dry eye, that you should not take your medications. No, it is completely the opposite. If you notice that your eyes are feeling dry, come see the ophthalmologist and we can help you with that. And autoimmune disorders, like rheumatoid arthritis, lupus, any kind of autoimmune disorder can lead to dry eye. And the common name is dry eye, but I like to call it dysfunctional tear syndrome, DTS. Why? Because really, your eye isn't exactly dry. What you may notice is that your eye is watering more than normal. The reason why is because, remember we talked about in that earlier slide that there are all kinds of mixtures in the tear film. Well, the tear film is made of 3 components. And if you're missing one of those components, like the oil, then what's going to happen is your tear film is going to make more and more and more tears because they're going to say we don't have enough oil, and then you get an overproduction of tears. And if you may notice some of the symptoms, contact lens intolerance, vision problems, a dry, gritty sensation, burning, sometimes certain facial plastic surgery can predispose you, diabetes, and smokers especially. Something else that can happen is rosacea. With rosacea, some people call it like an adult acne, but it can affect the skin around the eyes and lead to a reddish face, stinging eyes, but this can be treated with antibiotics. Now, we come to the cornea. As we age, you may notice a white ring around the eyes. And in people with dark irises, brown irises, it may make the eyes appear bluish. What is this? This is a deposit of cholesterol. It doesn't harm the vision, but if it happens when you're younger, it is important to make sure that you go to your primary care doctor and test your cholesterol levels. Because in younger people, it could be a sign of high cholesterol. And younger means anybody below 50. This is a pterygium. And pterygium means wing-shaped. This is also called surfer's eye because it occurs in people who spend a lot of time in tropical climates, in the sun and dust. And it's just an overgrowth of tissue. Now, sometimes it's just small and just comes just along here and we watch it. But when it starts to go towards the center of the eye, it can actually affect vision. If it does, then we treat it surgically. To prevent pterygium, it's important to wear sunglasses if you're in a dry, dusty environment with a lot of sun, and also keep your eyes lubricated. This is a pingueculum. A pterygium can start off like a pingueculum, very, very small. And it hasn't quite grown onto the cornea yet, just on the edge. And it's caused by the same irritation over time from dust and sunlight. Let's talk about some of the ocular manifestations of rheumatoid arthritis. I mentioned dry eyes. It can cause problems with the cornea. With the conjunctiva. You can get episcleritis. I'll show you what that looks like. It's red, angry, and it's irritated. It can cause all this itis, this inflammation. It can cause inflammation on the sclera as well. It can lead to corneal ulcers, and uveitis is inflammation inside the eye. This is scleritis. You see how angry that looks? That's just not a normal red eye. This is another picture here. And when we see this, sometimes we can treat it with drops, but if it gets worse, we have to involve the primary care doctor because it can lead to thinning of the sclera. If we see this, then we make sure, even before it gets to this point, that the patient is on medications such as methotrexate or Humira to try, or prednisone, anti-inflammatory medications to try to quiet down the inflammation. Another disease that causes inflammation is thyroid problems. And thyroid problems in the eye can cause all kinds of problems from the front to the back. You may remember, some of you, Barbara Bush had thyroid eye disease. And you remember her eyes were very big. And you see the soft tissue swelling here and here. The eyes are open wider than normal. Normally, you don't see the sclera, the white part of the eye, above. You normally see it below, but here you see it all around. And this can lead to dry eye, lead to tearing, burning, irritation, and trouble seeing. You see these eyes look very irritated. And you see there's irritation all the way around. But for the primary care doctors in the audience and the patients, it's important to know you don't always need surgery for this. We have new medications. There's a new medication now that can be used to help to quiet this. But as always, it's important for the ophthalmologist and the primary care doctor to work together to make sure that the patient's thyroid disease is being treated properly and medically. Let's talk about glaucoma. Glaucoma is very important to discuss because we say it steals your vision like a thief in the night. You don't even know it's coming until it's very at the end stages. You don't even know that you have it. And glaucoma is very common in Africans and African Americans. Age is a risk factor. I just mentioned African ancestry, Asian ancestry, being nearsighted, meaning you can see up close without glasses, but not far away. Family history. It's definitely important for you to know your family history. So we talked about the optic nerve. When I look in your eye, this is what I like to see. This is the optic nerve. And this little small lighter area is called the cup. And it should be nice and small like this. This is a picture of an optic nerve. But you see the cupping, the lighter area is a lot larger here compared to here. How do we test for glaucoma? Well, glaucoma is like three, like a puzzle with three components. We look at the visual field, we look at the intraocular pressure, we look at the optic nerve, and actually there's a fourth part. Now we look at something called the OCT. And I'll show you what that looks like. But this is the patient here, and they put their chin here, and you see they're holding something here. Every time they see a light flash in this bowl, they press the button. And glaucoma steals your vision from the sides, from the periphery. So this tests your peripheral vision. This is the blind spot. Everybody has that. All of this you see here is nice and light. But you see here, where it's dark, the patient missed all of this. So this patient isn't seeing well. And you see the whole top half of the visual field is almost gone. This is how we put everything together. We look at the pressure, and people often ask me, what is the best pressure? Well, it's very individualized. Usually we say, in general, we like it to be below 20, but for some people, a pressure of 20 is not low enough. We may need to get it down to 12. So your ophthalmologist will determine what is the best pressure for you. This is an OCT. And you can see here, this test is sort of like a stoplight, where green is good, yellow is caution, red is not so good. And if you look here, you see all of this, see all these peaks? Sort of looks like an EKG, but look how much of it is in the red. Then you look here, you see a lot of red and yellow. And then you look at the optic nerve. You see how pale it is, how big the cup is. And then you look at the visual field, and you can tell this patient has lost a lot of vision. Compared to this is a normal optic nerve. And you see, you can have some cupping, but it's not just looking at one thing, it's looking at everything together. And you see, all of this is in the green, this is in the green, and look, the visual field looks fantastic. Now, let's move back and talk about the back of the eye, the retina. The retina is like the film in the old-fashioned cameras. And if you remember those cameras, you wanted to make sure that the film remained pristine. You didn't want to expose it to light or dust or gravel, and you wanted it to remain perfect so you can get a good picture. Well, it's the same thing with the retina. And in the United States, they account for about 30% of all legal blindness. There's macular degeneration, diabetic retinopathy, blood vessel problems related to high blood pressure. Let's talk about diabetes first. Diabetics can get earlier cataracts. They have an increased risk of glaucoma and an far higher increased risk of retina problems than the average population. Diabetic retinopathy is a major cause of vision loss. Sometimes we treat it with laser surgery. You have to do regular eye exams. Sometimes we have to do injections, and sometimes we have to do regular conventional surgery. This is what an eye with non-proliferative diabetic retinopathy looks like. Non-proliferative means that there are not new blood vessels growing. So proliferative means to grow. So, and we're talking about blood vessels, so there aren't new blood vessels. But look, this doesn't look like that retina you saw in the beginning. This is blood leakage. It leaks out from the blood vessels. And when blood can leak, you can also get lipid leaking. And this can lead to swelling. You can also get what we call microinfarctions, like little heart attacks, because the nutrients aren't coming from these sick blood vessels like they should. And sometimes little parts of the retina can die. We call those cotton wool spots. But that's a sign that the blood vessels are very, very sick. Then you can get proliferative diabetic retinopathy, which means new blood vessel growing. And you can see here, to do that, these are new blood vessels, kind of like in a fan, fanning out. And those new blood vessels can leak, and you can get hemorrhages. Sometimes they're just small hemorrhages. Sometimes they fill up the entire back chamber and even covers the pupil, and the person can't see. So when this happens, we also treat with laser to try to make sure that we have to kill off some of the retina, the peripheral retina, because we want to preserve the interior part of the retina, which is where you see the sharpest. Now, the only way you'll know this, to catch this, is to have regular eye exams. So it's very important for the primary care doctor to send their patients to the ophthalmologist at least once a year. And if the ophthalmologist sees a problem, then they will let the patient know, and you may have to come more often, but at least once a year. What are some of the other problems? Well, high blood pressure can lead to a lot of problems in the retina as well. Just like high blood pressure can lead to problems in your heart. That's called a heart attack. You can get the same thing in your retina. And I'm going to show you what some of those things can look like. There's a central retinal vein, and sometimes that can become blocked. It can become blocked due to high blood pressure. It can become blocked due to stress, like if you're driving in DC traffic and you're, oh, what's going on here? Or it can become clogged due to cholesterol. And if you look right here, you can see there is a vein, and you can see it's narrowed. Almost looks like it stops and then starts again. That's called AV nicking. When we look in the back of the eye and see that, we know that the blood pressure generally needs to be better controlled. But this central retinal vein happened back here. And what happens is, just like you have the hose when you water your garden, if you were to take that hose and squeeze it and you still have the water coming on, eventually what's going to happen? That hose is going to bust from the sides because it can't come out the front, and it's going to bust from the sides and all the water will leak out. Well, the same thing happens here. All the blood leaks out and you get some lipid there, some infarctions, some swelling. And it's hard to treat, but we do. But this patient probably will not get 20/20 vision back. The other thing that can happen is the arteries. The arteries also can become occluded. And when that happens, it's a sudden vision loss. It's like you just turn off the lights. And sometimes it's not even painful. It's just like the lights get turned off, black. And it can be related to carotid artery disease, meaning a thrombus or high blood pressure or aging blood vessels. And because these artery, the tissue isn't getting fed, it turns white. And you see that. This is a branch artery occlusion, so that's good. It's only the lower half here. But you can get a central artery occlusion, and that's when you have complete vision loss. This patient would not be able to see the top half of the visual field. It would be black. And once this happens with the central retinal artery, we cannot get the vision back at all. It's sort of like having a stroke. And oftentimes when I see this in patients, I tell them it's good that we caught this now, because this is sort of like a warning sign that you are at risk for a stroke, and we have to do more to control your blood vessel, your blood pressure and your cholesterol or whatever the underlying cause is. So I think of it as an early warning sign. It's often sad that they may lose vision in one eye, but at least they still have their life. Vitreous separation. Remember I talked about the vitreous, and the vitreous helps to maintain the shape. And when we're first born, it's like the consistency of a raw egg white, very sticky. And as time passes, it becomes more watery. And as it becomes more watery, it can pull on the outer edges of the retina, and you can get flashes of light because you're stimulating the retina. If it pulls too much, you can get little tears that can lead to a retinal detachment. You can see the proteins kind of clump together as it's more watery and they float around, and you can get floaters. Now, this is a common thing that happens. But if you do get a sudden onset of flashing of lights or floaters, go see your ophthalmologist, because if you do have a tear, it's easy to repair that. Now, let's talk about cataracts. Everybody knows hears about cataracts. And what happens with the cataract is you start to lose your vision. And that lens that I talked about starts to get opaque instead of being nice and clear. And cataract surgery is probably the most common, if not, or the top 3 common procedures done in the United States. And we've been doing lens implants for many years. So again, here's our eye. Remember, the cataract is in the center. A lot of patients think, oh, is a cataract on the top and you scrape it off? No, it's in the center. So we have to make an incision to get here and remove it. And the good thing, it's a leading cause of reversible blindness in the United States and throughout the world. People can become blind from cataracts, but once we take it out and put it in the lens, we can restore their vision. What are the symptoms? People will notice routine activities become difficult, they become blurry. You may need to change glasses more and more frequently. So we remove the lens and we put in a clear synthetic lens. Well, a lot of patients hear surgery and it makes them nervous. But I tell them this is the best time to be living and having cataract surgery, because actually we can improve your vision. So at first we only had what we call monofocal, which means one focus lens. So you would definitely need to wear glasses afterwards. And usually we would choose a lens that will give you good distance vision. And then you would need glasses for up close and near, or if you had astigmatism. But now, look, we can have a lens that can correct for astigmatism and also give you good intermediate, close, and far vision. And this is simulating that. And even correct for astigmatism. And it just makes you much, much, much less reliant on your glasses. So I tell people when they get this, they can get through about 90 to 95% of the day without glasses. Now, if they're reading very, very fine print, they may need to pop on their glasses. But most people are fine. And I've never had anyone who has not been happy with those lenses. Lastly, you may have heard of laser cataract surgery. Doesn't mean the whole thing is done by laser, but it helps because normally we have the lens, the cataract, and we have to emulsify it. The laser helps to emulsify it and make it sharper, but we still have to use conventional surgery techniques to remove it. So in summary, this has just been touching on some of the things that the ophthalmologist and the primary care physician can work together so that the patient does well. But it definitely is a team effort. One can't exist without the other. I want you to remember, most people have good vision, and if they don't have good vision, they need to be seen by an ophthalmologist so we can see what's going on. I'd like to thank you so much for your attention, and please let me know if you have any questions.
Thank you so much, Dr. Bovell. I want to say that that was very informative. And let me move to the chat box. I think we have a question. So can you share more about what the risk factors are for glaucoma?
Yeah.
Three-part questions. Let me just ask the three questions all at once.
Okay.
What are the risk factors for glaucoma? Are there any COVID-19 manifestations in the eye? And what are the differences between optometry and ophthalmology?
Okay, all right. So the first question, what are the risk factors for glaucoma? Well, the number one risk is family history. So please talk to your parents, your aunts, uncles, sisters, brothers, and find out if they have glaucoma. Now, just because they say no doesn't mean that you can't have glaucoma. Highly prevalent in Africans and African Americans. It just is. That's just the way it is. And if you are African or African American, you should see an ophthalmologist once a year, at least, so we can just take a look and see. And this doesn't just happen in younger people. In older people. I've seen it in 20s and 30s. And just so you know, glaucoma, there's such thing as congenital glaucoma and juvenile glaucoma. So it doesn't mean that, if you have a kid, 10, 12, they need to be checked. No, usually in that age, well, congenital glaucoma, we can tell at birth because there's certain changes in the eye that we see at birth. I've been mostly talking about open angle glaucoma, but there's something called narrow or closed angle glaucoma, and you get attacks. And let me see if I can show you where that might be. Okay. Are you seeing my screen now? Okay.
Right now.
So let's see. Okay. So if you remember here in our picture of the eye, the fluid flows out here in between the iris and the cornea. So it has to have an angle that's open. Sometimes it can become narrowed like that. And if it becomes narrow, there you'll see it'll be painful, the eye will become red, you can see halos. So if you have something like that, of course, you're gonna go to the ophthalmologist, they can see that it's narrow angle and we can do something about that. That tends to happen more maybe in Asians, but it can happen in anyone. So diabetes is a risk factor for glaucoma as well. I think the next question was some of the manifestations, ocular manifestations of COVID.
That is correct.
Yes, we have seen that. So remember, the COVID virus is a virus. And just like sometimes when you get a cold, which is caused by a virus, you can get conjunctivitis, which means the conjunctiva here can become red, swollen, irritated, tearing. That can be, we've seen that. Also, with COVID, as you may know, COVID causes inflammation throughout the whole body. That's why it can affect different parts of the body in different ways, because it's really an inflammatory, causes a lot of inflammation. So again, we can see that inflammation for the most part in the retina. So remember, we talked about the vascular occlusions. Well, we're seeing that. Let's see. So here, we're seeing maybe more, not central retinal artery occlusions, but branch artery occlusions, or retinal branch vein occlusions, or we may be seeing retinal artery occlusions. So those are some of the things that we see. And then lastly, what is the difference between an ophthalmologist and a optometrist? Well, an ophthalmologist has gone to medical school, and then after medical school, then we specialize in ophthalmology. And there we learn how to treat the whole of the eye problems, both medically, surgically, how to diagnose. So we are at the top of the field. And then some of us may go on to specialize in certain parts of the eye. And some specialize in cornea, like I do. Some may specialize in retina, dealing in the back. Some specialize in neuro-ophthalmology. There's a pediatric ophthalmology is another, oculoplastics, which deals with the bones and the muscles and the skin around the eye. So there are many, many types of specialists just dealing with ophthalmology. Just like With internal medicine, you can have a cardiologist, you can have an endocrinologist, pulmonologist, nephrologist, all of those specialties. Well, we have the same specialties as well. Now, an optometrist has gone to college, and then they go to optometry school. And then in optometry school, they learn about the eye, but they don't know the same depth just because of time as we do, as far as the interactions with the whole body. And they don't do surgery, but they're usually able to look at the eye, generally if your eye is healthy, help you with glasses, contact lenses, and then, they know when to refer to the ophthalmologist.
That's a nice response to that, because I often wondered what the differences were. Now I know better. So we have another question for you. Are there any contraindications to cataract surgery, or certain patients who you would not recommend it for?
Okay, that's an excellent question. When we do cataract surgery, remember, it's an operation. So I always make sure my patients, I talk with the primary care doctor, and I say, hey, is this patient well enough to undergo this procedure? The other thing is I want to make sure that the eye has the potential for good vision. Now, sometimes there may be a reason and that eye doesn't have potential for good vision. Perhaps they've had a retinal detachment. The retinal detachment, it has been so severe that they're not going to regain any good vision. So then I don't want to put that patient through a surgery if I don't know that the benefits outweigh the risks. Now, just because I know I can't get a patient to 20/20 does not mean that the benefits don't outweigh the risks. Sometimes we have patients with glaucoma, and we know we can't get them to 20/20, but we can remove the cataract and improve vision. Sometimes we need to remove the cataract so that we can get a good view of the back of the eye. Here, the back of the eye, so we can see what's going on. Sometimes a retina doctor will say, hey, I can't see the back of the eye. I can't see if this patient's glaucoma or if their diabetic retinopathy is getting worse or not. So sometimes we have to do it for that. And it's also involves the patient. The patient needs to be involved. So sometimes the vision can be slightly decreased and the patient says, hey, doesn't bother me. I don't notice it. And if it's not that bad, I'll say, okay, that's okay. We can watch it. Or I may say you have cataracts, but they're not to the point where you need to have them removed. But the important thing is that in elderly people, removing cataracts generally is a good thing because it can prevent falls. Why? Because you can see better. If you can see better, you're not going to slip and fall and break a hip and have increased sickness and disease and all kinds of problems. That's an excellent question.
Great. We have time for maybe two more questions. Another question is, what is the natural history of uncorrected lazy eyes in kids?
Oh, good question. So generally, when you're first born, the visual system has not completed development. So kids maybe see around 2200 or so. And in order for them to get that stimulus so that they can get to 20/20, They have to be able to focus, and they have to be able to look at things, both distance and near. Now, as we talked about cataracts, some kids can be born with the cataract. And if you don't get that visual input, what happens? The eyes naturally tend to want to go out. That's naturally, but I'm always looking at something. You all are always looking. So that helps to keep our eyes straight. And they don't go out all the way like that, just a little bit. Sometimes there's a palsy. So the eye will tend to go out or in or up or down. But in order for the retina to get the proper stimulation, I'm going to go here, here again. And we want, here we are, where's my pointer? Oh, here it is. Okay. This is the part of the eye, the macula, that has the best vision. And so you see, if that part of the eye is not stimulated, then the eye will tend to turn out or in, and the patient will not develop good vision. And our vision develops through the age of about 8 to 10, I'd say about 10. So if that lazy eye is not corrected prior to age 10, then the child will never develop good vision, meaning they won't be able to get to 20/20. So it's very, very important to notice that. And sometimes you notice it in pictures. You know, kids are always running around doing things. They're hardly still. So you're not going to get a kid to just look like that for a long time. But if you notice in a picture that the eye is turning out or in, then see your primary care doctor, and they can refer you to a pediatric ophthalmologist. So uncorrected lazy eye can lead to poor vision.
Okay. So one last question I think we can squeeze in here is, sometimes after reading long texts on the phone, I know this, I'll speak in the first person. Sometimes after reading long text on my phone, I notice some blurring when I look up. It doesn't happen with print, just digital media. How would you explain this?
Sure. Well, with digital media, we have that light coming to our eyes, the blue light, and it's not the healthiest for our eyes. There may be two things going on. You may be becoming what we get called computer vision syndrome from looking at that blue light. You may have a little bit or early dry eye or dysfunctional tear syndrome. Also, depending on your age, you may be in the early stages of perhaps right on the border of needing reading glasses. So what happens is when we need reading glasses, when we look up close, our lens gets tight in a ball like this. But as we get older, it doesn't go back and forth as quickly. And little kids can get in a ball. That's why they can read up close like that. Most of us can't do that. So if you're used to reading up here and your lens is here in the ball shape, and then you look out into the distance, it may not bounce back. It can get back, but not as fast. That can be one reason. The dryness can be a reason. And like I said, looking at the computer, even with the phone as small as it is, you can still get computer vision syndrome.
Thank you for that. And a follow-up question real quick to the lazy eyes. How is this corrected? I know you did say refer to the pediatric ophthalmologist, but do you have any idea? Is it surgery? Is it wear glasses, eye drops?
Sure. Okay. Well, first we have to determine the cause. So if the lazy eye is due to a problem with the lens, say a cataract, we remove the cataract. If it's due to a weakness in the muscle, then sometimes we patch the good eye to make the weaker eye align straightly. But that has to be done very judiciously, because then we don't want to turn the good eye into a bad eye. So it can be done by patching. Sometimes we use drops called atropine to make the vision in the good eye weak. So again, that forces the good eye to be used. Sometimes it's surgery. So if you have the eyeball, this is the eyeball, there are muscles here, 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 and one here and one that way. But generally, this muscle here, when it contracts, it pulls the eye that way. This muscle pulls the eye that way. So a muscle pulls it up and a muscle that pulls it down. So if one of the muscles, let's say one of the muscles is weak and the eye tends to turn out, or maybe it's easier if I do turns in, then we can pull this muscle this way, shorten it a little bit to make it stay in its right position. So that's surgery. So sometimes we do muscle surgery on the muscles around the eyeball. Hopefully that was helpful.
It was. I think that's all we have time for. So
okay.
Thank you so much for an informative presentation, as always, Dr. Bovell. On behalf of Anpa DMV chapter, I want to say thank you for being our special guest speaker for this education series on eye health. And now I walk away knowing that my eyes are the window, is the window to my health. I didn't think about it that way, but that was a very nice caption.
Yes.
Thank you very much.
Well, thank you for having me. It's my pleasure. And I always feel like I learn a lot by these questions. Excellent questions.
Okay. So
thank you, Dr. Bovell. Thank you so much. This was excellent, and it's recorded. I don't think we did it justice by not getting the flyer out with sufficient time. But fortunately, it's recorded, and I'm pretty confident it'll be well received once we disseminate the recording. But really, really appreciate the time and the quality of the presentation. Thanks again.
My pleasure. And it's okay, because that way everybody hopefully got their questions answered. So that's good.
That is good.
Everybody is.
All right. Well, have a great weekend. It's lovely outside, and I can't wait to actually have a christening to go for. So thank you again for your time, and thank you for everybody for attending. Goodbye.
Take care.